This is a dictation patient Hawkins, Hawkins, Marian, Marian. Please address it Dr. Lostein, Lothstein, initial D, paragraph. Thank you for referring Marian, who is 76-year-old female. With respect to ongoing care for rheumatoid arthritis stop, Marian has been a patient of a colleague of mine, Dr. Alderdice, in Guelph, who just retired. She has been diagnosed with RA over 20 years ago by another rheumatologist. She has been treated initially with anti-inflammatory medications, and she also recalls being treated with combination of Plaquenil and methotrexate. She had difficulty tolerating methotrexate, and eventually that therapy has been stopped. She has not responded to Plaquenil, and was subsequently to it changed to Enbrel in 2004, on which she remained up until 2013. That year she has been diagnosed with ovarian cancer and treated by surgery and chemotherapy. In 2016, she received one dose of Rituxan, which was not very effective, and eventually placed on Areva 20 milligrams per day, which has been controlling her pain and swelling quite well, and which she tolerates okay. In 2017, she had MI and recovered quite well. She also has partial hysterectomy history at age of 34. Paragraph. Marian also has hypothyroidism and osteoporosis with no history of clinical insufficiency fractures. She lost some height historically. Stop. She is also known to have OA and had bilateral TKR in the past. Stop. She also has mild glaucoma. Stop. Her other medical history includes mild COPD, sigmoid diverticulosis, GERD, and history of shingles in July of 2016. Her both knees were replaced in 2006 and 2007. Stop. Her last BMD was done in 2013 and showed a low bone mass. Stop. She had a low bone mass per stop. She also has history of thyroid cancer treated by surgery many years ago. Paragraph. At the present time, she has minimal joint pain, mostly in the left shoulder, where she is known to have rotator cuff tear and OA, and mild achiness in her toes and fingers without any swelling or more than 10 minutes of morning stiffness. She is on meloxicam, which helps and works for this quite well. Stop. She has no history of rashes, including psoriasis, symptoms of Raynaud's or Sjogren's. Stop. Her energy level is quite stable. Stop. She has been losing balance and fell within the last year 3 times, luckily not fracturing any of her bones. Paragraph. Current medications: meloxicam 7.5 mg OD, Areva 20 mg POOD, atorvastatin 40 mg OD, candesartan 8 mg OD, Lasix 20 mg OD, levothyroxine 1 to 5 mcg OD, metoprolol 50 mg OD, Pantelog 40 mg OD, Lumegan drops, Prolia injections. vitamin B12, vitamin D 1000 IU/OD, ASA 81 mg/OD, and Tylenol PRN. Paragraph: allergies, penicillin, ACE, paclitaxel in bracket anaphylaxis, Combigan GTT, and lobster. Paragraph: FHX. Father, MI, mother, glaucoma, 2 kids, daughter, Raynaud's, son died in an accident. Paragraph. Paragraph P/E. BP 127/70, no pedal edema, and normal heart sounds, lungs clear to auscultation. MSK exam revealed limited mobility in the left shoulder due to pain, and small localized swelling over the dorsum of left wrist, as well as OA changes at both CMC, DIP, and PIP joints of both hands, and multiple IP joints of toes, with no evidence of joint line tenderness, stress pain, or synovitis. Paragraph. Laboratory investigations that were done by Dr. Alderdice every 8 weeks showed in September of last year normal CBC, platelet count ESR 80. BMD from APR/1H showed T-score of 1.1 at the L spine and minus 1.9 at the femoral neck. Stop. X-ray of the left shoulder shows degenerative changes at the left AC joint, as well as GHJ. Stop. MRI in 2004 of right wrist shows erosions at the second and fifth MCP joints. Paragraph impression. Marian has osteoarthritis as well as rheumatoid arthritis for over 20 years. Her rheumatoid arthritis is well controlled with Areva, and she will continue that therapy. She is symptomatic, more so from her OA. She was advised to remain on meloxicam at this dose, or use it only as needed, and increase Tylenol extra strength to 2 tablets 3 times a day. Stop. She was referred today for baseline blood work as well as x-rays of hands, wrists, and feet and spine to rule out possibility of vertebral fractures. She was also referred for bone mineral density. And was for bone mineral density. Stop. She will continue Prolia injections every 6 months. Stop. Lastly, she was provided with requisition for follow-up blood work every 8 months, which she can do locally. Stop. Thank you for referring Marian under my care. Stop. Patient Weaver, Weaver, Karen, Karen. Please address it to Dr. Suraj, Seuradge, initial G. Thank you very much for referring Karen, who is 61-year-old female, with respect to possible Raynaud's. Stop and paragraph. Karen has been experiencing white as well as bluish purple discoloration of all fingers. Since December of last year, she probably had 4 or 5 episodes. All fingers are involved. She's also experiencing numbness and paresthesia on a daily basis. She just had nerve conduction studies which showed sensory neuropathy. Stop. She has not been experiencing any joint swelling or swelling of her fingers. She also has no changes in the skin texture, no history of rashes, photosensitivity, mouth ulcers, or alopecia. Her respiratory, cardiac, and abdominal inquiry is negative. Stop. She has a history of breast cancer, stage 2 ductal CA, ER positive, in 2005, treated with chemotherapy, 4 months of chemotherapy, ACT, and radiation for 5 weeks in addition to surgical treatment. She was also on tamoxifen 2005 to 2010 and is currently off with no recurrences. She also has history of colonic polyp, tubular adenoma in 2017, and will have follow-up colonoscopy in 2022. Her gastroscopy showed GERD. Paragraph. Current medications: Pantelog 40 mg OD, glaucoma eye drops. Paragraph. Allergies: sulfa. Paragraph. FHX uncontributory. Paragraph. She is non-smoker. Paragraph. P/E, BP 123/70, no pedal edema, no rashes, telangiectasia or petechia, also no evidence of digital pulp atrophy or ulcerations, and no periangle erythema or dropped capillaries. No evidence of skin tethering or sclerodactyly, normal heart sounds, no added sounds, murmurs or rubs, lungs clear to auscultation. MSK exam reveals no evidence of either tender or swollen joints. Paragraph. Or swollen joints. Stop. She had small degree of OA changes at the IP joints of both hands. IP joints of both hands. Stop. Paragraph. Impression. Karen has Raynaud's phenomenon. Based on her overall presentation, there is no clear evidence of connective tissue disease. However, she will require further of connective tissue disease. Blood work that you send me shows negative ANA, ENA, and anti-double-stranded DNA, as well as negative anti-CCP and CRP of 1.1. I suggested follow-up blood work in November. Stop. She was counseled with respect to with respect to Raynaud's and advised to protect herself from cold environments. and was given appropriate pamphlet regarding this. I will review Karen again in December of this year. Stop. Thank you for referring, Karen, for consultation. Stop. Anna Jaroszyńska. Brazeau, Kevin, Kevin. Please address it to Dr. Youssef. Youssef, initial V. Thank you very much for referring, Kevin, who is a 30-year-old male with respect to possible connective tissue disease. Stop and paragraph. Kevin tested positive for ANA 1/80 SP speckled pattern and had a normal ENA and had negative ENA and anti-DS DNA screen and otherwise unremarkable blood work. Stop. He has been experiencing headaches, occipital as well as temporal and frontal, and has been seen with by neurologists and diagnosed with tension headaches. He has been prescribed some muscle relaxants, which are not very effective. He has not experienced any double vision, and he has no history of rashes, photosensitivity, mouth ulcers, or alopecia. He does have pain over the left. He has pain over the left lower rib cage and at times has some stiffness in the mid-thoracic spine. The pain in the lower chest can get worse with inspiration. He has no cough or shortness of breath. He had echocardiogram done a few months ago and it was normal. Also, MRI of the head was normal as well. Stop. He has no history of serosities, seizures, psychosis, or thromboembolic complications. He also has no symptoms suggestive of Raynaud's or Sjogren's. He has no paresthesia in hands and feet. He is non-smoker, paragraph, current medications, none, paragraph, allergies, none, paragraph, FHX, DM, CAD, and jaw problems. Paragraph, physical exam, BP 123/70, no pedal edema, no rashes, no telangiectasia or petechia, no thyroid enlargement, normal heart sounds, lungs clear to auscultation. MSK exam revealed no tender or swollen joints. A range of motion in the spine was normal. Paragraph. Additional blood work showed normal CBC and differential CR7-8, normal TSH, B12, ALT 20, CRP 0.3, negative RF, and Hep C serology. Paragraph, impression. Kevin has no evidence of connective tissue disease. I'm not quite sure how to explain his left lower rib cage pain, but I referred him for chest x-ray as well as abdominal ultrasound with the copies to be sent to you. He will also do some additional blood work and I will call him in case of any concern. Stop. Thank you for referring, Kevin, for consultation. Stop. Mitreski, Mitreski, Vlado, Vlado. Please address it to Dr. Moghadam Abrashami, Moghadam Abrashami. ABRISHAMI, initial K paragraph. Thank you for referring Vlado, who is known to me, 42-year-old male with respect to a recurrent triggering of right fifth digit. He was seen by me originally in August of 2017. With the same problem, and he responded extremely well with resolution of his symptoms to symptoms after cortisone injection. He has been asymptomatic for a long time, and only recently triggering reoccurred again. He is otherwise quite healthy and has no history of PSO. IBD or uveitis stop. Or uveitis stop. He remains on no medications and he has no allergies. Paragraph. P/E is unremarkable except for minor OA changes over some of DIP and PIP joints. He also had tenderness to palpation along right fifth flexor tendon. There was no evidence of synovitis or dactylitis. Paragraph. Impression. Vlado has recurrence of right fifth digit flexor tenosynovitis. This might be related to his work. I will re-inject him with cortisone. But if he's not going to respond to it, or if he has a recurrence in the future, please consider referring him to one of the hand surgeons for surgical treatment. Stop. Lavoie, Lavoie, Julie, Julie, initial P. Please address it to Dr. Harris, Harris, initial L, and send a copy to Dr. Skendaj, Skendaj, initial E. Paragraph. Thank you very much for referring Julie. Regarding possibility of connective tissue disease in view of her abnormal ANA serology. Paragraph. Julie has multiple symptoms that started to occur after she had bilateral breast implants in 2010. She has been experiencing tightness and pain around her breast as well as entire rib cage associated with pulling and possible swelling. She also has history of indigestion and daily vomiting and severe gastritis that was diagnosed after gastroscopy in Quebec in 2014. Her biopsies for H. pylori and celiac disease were all negative. She was treated with antacids and improved. She's also experiencing chronic cough, which has been felt to be related to post-nasal drip. She was seen by ENT consultant regarding that. Stop. She has no history of rashes, photosensitivity, recurrent mouth or nasal ulcers, and no history of alopecia. She does have history of acne-like rash on her back, which started about 3 months ago after implants were inserted. There is no history of serosities, seizures, or psychosis. She is known to have Raynaud's for a number of years, affecting toes and fingers, and that started after implant insertion. Most of all, she has been struggling with recurrent PVCs and had echocardiogram, which was done in 2017, and that was normal. PVCs were documented by Holter. 2 months ago, she had PFTs, which were normal. She has paresthesias in both hands and intermittent achiness at elbows and knees with no joint swelling. Stop. She feels very tired and stiff for years and quite anxious. Stop. She had 2 ovarian cysts removed 3 months ago. Stop. She has no symptoms suggestive of Sjogren's, no fever, chills, weight loss, or recurrent lymphadenopathy. Stop. She also has not experienced any changes in the skin texture. Paragraph. Current medications: vitamin D2 50,000 IU/OW, coenzyme Q10, omega-3, magnesium. Paragraph. Allergies: none. Paragraph. FHX, CAD, mother, father well. Julie is a former smoker for 8 years, as a late teenager, early 20s. Paragraph. P/E. BP 125/70, no pedal edema. Skin inspection reveals small acneiform-like lesions on the back and chest, no telangiectasia or petechia. No thyroid enlargement and no lymphadenopathy. Normal heart sounds, no murmurs or rubs. Lungs clear to auscultation with no crackles or wheezes. Joint examination reveals no evidence of either tender or swollen joints. Paragraph. Blood work: ANA 1/80, SP/hormone, CRP1 negative RF, normal TSH, normal CBC, normal differential, ESR2, creatinine 59, GFR 115. Paragraph. Impression. Julie presents with constellation of symptoms, with variety of symptoms, including chest and ribcage pain around breast implant site, fatigue, recurrent rashes, some nausea, vomiting, postnasal drip, and generalized malaise and some arthralgias. Her ANA result is borderline. Is really quite borderline negative, and those symptoms, apart from Raynaud's, are not clearly related to any type of connective tissue disease, and Raynaud's phenomenon can occur in isolation. She was referred for additional more in-depth blood work, as well as microscopic urinalysis, and I will contact her in case of any concerns. Stop. From my perspective, she was reassured that she has no clear evidence of connective tissue disease at this time. Also, research that has been done up to date showed no association between breast implants and connective tissue diseases. Stop. More work is still done in this area. There has been association with skin lymphomas in extremely small percentage of patients. She can further discuss it with her plastic surgeon if needed. Stop. Thank you for referring, Julie, for consultation. Mastro Carlos, MASTROKALOS, Laura, LAURA, initial N. Please address it Dr. Ruparelia, RUPARELIA, initial R. Paragraph. Thank you very much for referring Laura, who is a 30-year-old female with respect to possible inflammatory arthritis. Stop. And paragraph. Laura has been experiencing achiness in her fingers, knees, and feet for quite some time. Right third PIP joint especially can swell up, and that's been happening for the last few years. Stop. For the last few years. Stop. She has no history of psoriasis, IBD, or uveitis. She recalls her right third digit being swollen and resembling being swollen, in brackets question mark dactylitis close the bracket stop. She has no symptoms of enthesitis, no history of IBD or uveitis paragraph. She is otherwise quite well and asymptomatic paragraph. Current medications, Ventolin for asthma, paragraph allergies, penicillin, amoxil, erythromycin, paragraph FHX. Both parents well, but there is history of RA and OA on both sides of the family. Paragraph, she is a smoker and is trying to quit. Paragraph, she is usually stiff in the morning for about 15-20 minutes and that improves with activities. Paragraph, P/E, BP 121/70, no pedal edema, no rashes and no nail lesions, normal heart sounds, lungs clear to auscultation. MSK exam showed no evidence of tender or swollen no evidence. MSK exam, showed joint line tenderness, stress pain, and possible synovitis at the right third PIP. There was no dactylitis. She also had hallux valgus deformity with left toe being left first MTP being more deformed than right. No enthesitis. Paragraph, impression, Laura has possibly inflammatory arthritis. She was referred for relevant blood work and will also have X-ray and ultrasound of hands and feet. After this is completed, I will see her in follow-up and discuss in detail diagnosis and treatment. Stop. She agreed with this plan. On patient Cooper, Cooper, Joe Annie, J O -ANNE, NA is capital, initial F. Please address it to Dr. Bailey, BAILEY, initial G. Paragraph, thank you very much for referring Joanne, who is 70-year-old female, with respect to her rheumatoid arthritis, ongoing care for her rheumatoid arthritis. Stop. And paragraph, Joanne has a history of RA for over 25 years and she was under the care of my colleague, Dr. Carter Thorne, THORNE, in Newmarket. Stop. She relocated to Burlington. Stop. For her RA, she has been treated with methotrexate for extremely long time, probably more than 20 years. In the past, she recalls being on full dose injectable methotrexate between years 2006 and 2011, and currently she's on a tablet 7.5 milligram once a week. She has never required in the past any other disease-modifying antirheumatic drugs or biologics. She is not sure if her RA is RF and anti-CCP positive. She has no history of psoriasis, IBD or uveitis and no symptoms suggestive of Raynaud's or Sjogren's. Her energy level is quite normal. She has currently minimal, if any, joint pain and no swelling. She has no history of fractures and lost a little bit of height historically. Her last BMD was done in 2017. Paragraph, current medications, MTX, 7.5 mg POOW, folate, 5 mg OW, vitamin D, 2000 IU/day. Paragraph, allergies, none. Paragraph, a blood work done in March showed normal CBC and platelets, normal differential, CRP7, ESR23, CR GFR 61, GFR 89 paragraph, P/E, BP 128/80, no pedal edema, no rashes, no rheumatoid nodules, normal heart sounds, lungs clear to auscultation. MSK exam revealed OA changes at the right first MC, and also some of the DIP joints of both hands. She had no evidence of synovitis. Paragraph impression. Joannie has long-standing history of RA, which seems to be in remission on current therapy with methotrexate, and she was advised to remain at the present dose. She was sent for baseline blood work and was given requisition to do blood work every 8 weeks. She was also referred for BMD and spinal X-ray to rule out possibility of vertebral fractures. I will follow up with her in August. Stop, Anna Jaroszyńska.